Dr. Benita Zahn.
Good evening and welcome, and thank you for your patience. Technology, sometimes, you just got to go with it. As COVID vaccinations ramp up with the addition of the Johnson & Johnson vaccine, questions about vaccine efficacy, side effects, durability, well, they're coming fast and furious. So we've asked a trio of experts to get you answers, and our panel includes Dr. Eric Yeager, Associate Professor of Microbiology at the Albany College of Pharmacy and Health Sciences. Also with us is Dr. Alan Sanders, Chief Medical Officer for St. Peter's Health Partners Acute Care, and also an infectious disease specialist, and Hillary Allison, Director of Infection Prevention and Control at Glens Falls Hospital. Welcome to you all. A couple of things to note as we get started. As of today, people 60 and older can sign up for a COVID vaccine in New York. Over the last 24 hours, 143,592 doses have been administered across New York's distribution network, and more than 1.12 million doses were administered over the past 7 days. As of today, the New York Times Vaccine Tracker and the state say 19.4% of New Yorkers have gotten at least one vaccine, and 9.8% have gotten both. So let me start, panel, this way. How do these numbers begin, or are they moving the needle toward herd immunity? Help us out understand this.
I can start out, Benita. There's some estimates out there that the United States needs to have 70, possibly 80% of the people with immunity to have what we call herd immunity. It's a very difficult figure to account for right now, because even though we've had 30 million cases diagnosed in this country with positive tests since the beginning of the pandemic, there are probably at least as many as that who have not been diagnosed with the disease. So if you want to consider the people who are actually exposed and have native or natural immunity to the virus, I think we got to always consider counting those folks into the grand total with those folks who are going to ultimately get a vaccine. So if you want to start it out that we have, 10% of the population at this point vaccinated, so maybe 30 million folks, concentrated more in the older population, plus add on to that, I'm not going to make this, a statement that's with assuredness, but another maybe 60 million people who've been exposed. We have, gone fairly fast and over the last month with vaccines, but I think we need to consider that initial impact of the pandemic and what's going on through the last 8 months since the summertime. We probably have a lot of people who have immunity to this disease. That doesn't mean that we have herd immunity when we hit 70 to 80%. It means that we have a kind of a rolling immunity because of the potential for variants that are going to pop up in the community. And we don't know yet if the natural immunity in this country that hit people hard and gave them antibodies, and hopefully some, Eric knows better, we call maybe cellular immunity over a long-standing memory period of time, is going to be durable along with the vaccines to prevent the potential for somebody getting a second infection with the virus that will evade that antibody naturally or evade the vaccine. So we're hoping for 70 to 80%. Do the math. I'm talking about, 200 million people, 240, but we're well on that path to count the people who've been infected so far. So we just got to cross our fingers that the variants don't take hold in a big way for those people who've been infected before and had vaccines.
Yeah, and that's one of the unknowns at this point. So you opened the door to this next question. Doug asked, what's the likelihood we're going to need a booster, and how soon might that happen?
Eric, you want to answer that? I can handle it.
Well, sure. Thanks, Alan.
Jump right in. It's like I throw out the first pitch at the ball game, and now you're all the batters.
So I'll send him from first base to second here. So definitely, I think, as Alan mentioned, the concerns we have with the variants, and it is kind of a race now between getting people, towards enough immunity that we can kind of limit the spread in the community towards these variants that are appearing. And as we continue to do more genetic testing of the viruses, we become more aware of these variants. And I should mention, the variants simply arise because the virus mutates, like all viruses do. And the importance of a vaccination is we can prevent future variants, because the virus can't create more variants unless it's inside a person. It can't do this outside. It needs to infect someone during its normal process, like a copying machine. It's making more and more copies of itself, and occasionally an error is produced. And that can sometimes lead to a virus that's better able to transmit from person to person it may have the potential to cause more severe disease, and we're still trying to understand these variants. But we are able to track these, and the hope is that by understanding which of these variants become dominant, I think people have to remember too, from a virological and immunological standpoint, we're kind of watching a new virus unfold in the population. We think about viruses like influenza, and we have vaccines against it. So people wonder, well, we have influenza under control, why not COVID? And this is a new virus to the human population, so we're evolving, and the virus is evolving, and these variants are rising up, and we have to figure out which ones are going to become predominant, and then from that, can we start to build up booster vaccinations? And I think it's looking towards that we might need a vaccine, a booster, maybe yearly, biannually. We don't know yet what that's ultimately going to be. But really the idea that we can take the vaccine technologies that have been successful and hopefully use these to beat back those variants. But again, the kind of complicating factor here is we all can appreciate that the rollout of the vaccines has been a little bumpy at first. We're kind of on the right track, as Alan mentioned, but we have to worry and have some care to make sure we don't repeat, or those involved in rolling out these boosters don't repeat some of the same mistakes. And we have issues with accessibility in certain communities. We have issues with availability. So really we have to make sure that we can develop approaches to fix those issues before we try to complicate it by adding in, people that just got a vaccine 4 months ago, lining back up again to get a third shot of booster. So there's a lot to work out, but we do have the technology that if the variant becomes more problematic, I'm optimistic that one or all of these vaccine platforms will be able to help us out.
And we've got a lot of questions, so we're going to try to get through them as quickly as possibly, while still being thorough. Marsha wants to know, and you talked about, things changing so quickly, is there really enough testing on these drugs to test the shots? So give us sort of a thumbnail as to, the mRNA vaccines, the Moderna and the Pfizer, and they're not brand new in the sense that there's been a long history looking at this type of vaccine, or this type of how this is working, at least.
Yeah, I can just tell you that there's evolving data that's coming out all the time. We're getting some literature. Just yesterday, I think it was the day before, the New England Journal of Medicine put out an article for laboratory-derived mutants that mimic really the ones that are out there in the world right now. The UK variant, the South African variant, and the Brazilian variant. They actually modified these from the wild type or the original virus in the laboratory, and then they took serum or antibodies from people who've already been vaccinated with Pfizer, and these are people who've made antibodies already, and the vaccine, that is the serum from these people, look pretty good against these manufactured variants. And again, this is in a laboratory setting, it's not real life, but we're getting this coming out. The Israeli experience is showing that with a country that had 80% UK variant really hitting a huge second kind of camelback hump in November, December into January, when they started vaccinating large numbers of people, mostly people over 60 years of age, they had an abrupt drop in the numbers of new cases, thinking that the vaccine was matched well against that predominating species that is out there, the UK variant, and transmission began to go down. So, this is all a laboratory of dynamic real-life experiments we're doing with vaccines and variants all at the same time. And, I think of it kind of like, I hate to be a cartoonist here, it's kind of like the Roadrunner and Coyote. Like the Coyote's a virus, and the Roadrunner keeps trying to outwit him all the time. It's a very dynamic problem, and getting people vaccinated, and as Eric said, potentially modifying the vaccines, which is really pretty darn easy with this vaccine technology, and getting those boosters back into people. So I think there's a pretty good match right now. I think people ask what vaccine to get. The answer should be the one you can get quickest.
Alan, I want to jump in real briefly, and Hillary, I want to bring you into the conversation. A lot of folks are going, well, I don't know if I want J&J because the efficacy is a little bit less than what you see with Pfizer and Moderna. Can you explain what that all means and how the testing was done at a different time on that as compared to the first two shots?
Yes. So, well, The timing is different, but it's also, an opportunity. So there's a lot of folks who are not interested in receiving 2 different shots. A lot of people are just less comfortable with receiving 2 shots. So if they are willing to go for 1, but maybe not 2, then the J&J Janssen is the best opportunity for them. Or we do have a transient population where we may not be able to schedule a second appointment for those individuals. This is the ideal opportunity to as both of our doctors have said, this is the ideal opportunity to break the chain, to stop transmission in its tracks so that we can get ahead of this. Because honestly, vaccination at this point is our most straightforward path to what would be our normal life as we know it.
And is it as effective? That's the question a lot of people have. Is the J&J shot as effective? Is it as good as the Moderna and the Pfizer?
Yeah, so Moderna and Pfizer are running between, 94, 95% efficacy, and the J&J Janssen is running at 66.3, I believe, with just one dose. So while you have a smaller efficacy, it's still a single dose, and it is still a very effective vaccination for what it is.
Mm-hmm.
I would just add in that, sorry to interrupt, Hillary. I would just add in that, as Hillary mentioned, the Janssen J&J vaccine was studied up through December at the time of the second big wave. It was studied extensively in South Africa, in Brazil. Moderna studied only in the U.S. Pfizer was studied in other countries, but nowhere near the depth in those countries with circulating variants. So if you look at severe disease and hospitalizations up against J&J in those countries during variant circulation, it was in the 80% efficacy. So I think the vaccine, in terms of the time it was given and the domains that it was given in, looks pretty darn good. Because I'm not saying go study Pfizer and Moderna again right now, but I think if you look at it, that J&J vaccine in total had a lower number, but when you look into where it was studied and in terms of severity of disease, hospitalizations, no death, it worked, I think, pretty well.
Mm-hmm. And I've got a question from Mare. She says that her sister got both the vaccines back on February 22nd was the second. She had to get a COVID test yesterday because of a procedure. Her husband, she tested positive. Her husband had both vaccines. He tested positive. How is it possible that they would test positive for COVID after getting both shots?
So no vaccine is 100%. I think there's a couple things about vaccines. So just a finishing point on our last topic was people think of efficacy as kind of like a grade, right? Like, oh, I want an A+ versus a C. Well, again, those numbers are based on the studies. The more important number, as Ellen mentioned and Hillary mentioned, is that vaccines prevent hospitalization and severe disease. So you still might get sick by having the vaccine, because again, it's not 100% effective, but it's going to prevent severe disease, hospitalization. And for those individuals that are really susceptible, hopefully it's going to prevent fatal outcomes. So with this story of this individual that got sick, there's a couple of things. Again, first, the vaccine is, they can prevent disease or prevent infection. And we're still trying to learn really the ability of those vaccines to do that. So that gets to some other issues with, I've been vaccinated. Can I, stop wearing a mask? Can I go out more into restaurants and movie theaters? And that's a separate topic. But again, the vaccine is really preventing disease. It may not prevent infection. And hopefully the individuals, even though they were vaccinated, they got infected. But I would bet that their disease is magnitudes less severe than if they didn't get the vaccine to begin with. And if we can get COVID-19 to be like the flu or the common cold, then I think that's a win. And I think one last point about the vaccine efficacy is I think people need to put in context of what vaccines we have. So the flu vaccine, for example, its efficacy is like 40 to 60%, right? Now, we'd all take the flu vaccine. We know it's effective. It's preventing hundreds of thousands of hospitalizations, thousands of deaths. So we're kind of setting the bar a little too high with the COVID-19 vaccines. Again, let's focus on really the hospitalizations and preventing severe outcomes.
Which brings to the next question I had gotten a little bit earlier. Why only 90 days? That you don't need to quarantine for New York State. You get both shots, you're 2 weeks out, you travel, you come back, you got 90 days. But if it's longer than that, you're going to have to quarantine. What's the 90-day limit on these vaccines at this point?
Time. We need more time to study these. So we have 90 days of assured vaccination and protection. And as we go on in time, we'll be able to discover just how long those are effective. But, this is a new process for us. So we have to be able to have the time to study it, to ensure with assured confidence to say, yes, you have coverage for X amount of time. We have to actually have that time lapse.
So we're learning as we're going. Another question I had was, why do women report worse effects from the vaccine? What role might hormones, genetics, dosing even play in this?
I would actually question the age groups that are reporting that within the females, only because the side effects are really commonly distributed through specific age groups. I'm not sure that they're specifically gender related.
The other question I've got an awful lot lately is, what about taking, Advil or Tylenol pre-dose before you get your vaccine or after? Now, I know the CDC says don't unless you really have to. Where are we at with this now, and why?
I don't know that taking a medication that's going to last a couple of hours at most in terms of efficacy is going to do much for somebody walking in to get a shot in their arm. In terms of, they're not going to get an instant side effect. That's going to be aches and pains, muscles and joints, fevers, chills, feeling blah. It won't prevent anaphylaxis, obviously. That's the thing that's going to happen rapidly after the vaccine. It's happened in very, 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 very few people. But to take an anti-inflammatory or anything that's going to manage pain, the next day after you've had the vaccine, as opposed to preemptive, there's no real bad side effects that way in terms of impacting the efficacy of the vaccine or hurting somebody. Most people get over their side effects within a day, 24 to 48 hours at most. It is not contraindicated like it's going to cause problems for the individual. Most folks get by without having to take anything, and it's like getting through a bad flu for a day.
But it won't diminish the efficacy of the vaccine if you do.
No, because the chemicals, the non-steroidal anti-inflammatory medications or Tylenol or aspirin, they don't impact the body's response to these little pieces of genetic material making antigens and then antibodies coming in. There's no game they're going to get involved in there.
And we sort of touched on this. Lynn wants to know why, if you're vaccinated, do you have to keep masking and your social distance?
I was going to say, Hillary's point about kind of learning as we go, back to the idea of taking anti-inflammatories. It's based on kind of older data looking at different vaccines, that people that took some anti-inflammatories before getting a vaccine, they had a less robust immune response. And because we don't know all the information about how much immunity you need to be protected, we're kind of falling back on some data that we have from other vaccines. So as Ellen mentioned, I think you'd really have to take something really strong like a steroidal medication to really blunt your immune response. And certainly when I got my second dose of my Moderna vaccine, I did feel a little kind of fatigued and achy on the second day, and I did take an Advil, and I'm fine. As for the masks, I think getting back to the point that we don't know if the vaccine can prevent transmission. We still don't know, even after a year into the pandemic, how much virus someone needs to get sick.
So
we don't know yet, if those studies are going on, as to how much of a reduction in virus does someone have. Now, it's probably safe to assume someone that's vaccinated has less virus in their body than someone that's not. But again, we're still playing with the idea of an overabundance of caution, because we just don't want to put someone in a situation where they feel like, oh, I'm vaccinated, I'm kind of invincible. They visit their grandparents and their grandparents get sick and they're hospitalized. So it's better to err on the side of caution until we have a clearer picture about how effective the vaccines are at preventing transmission.
Yeah, and I think there was some research that came out today on the Pfizer vaccine that looks like the transmissibility, if you will, is very, very low. So that's all, as you've been saying, we're learning as we're going here. Somebody wants to know, Ruth wants to know if there is sulfa in the vaccine, and the answer is no.
No.
Okay, they had a concern about that because they've got, they are allergic to that. The other question I've had many times is, what's the difference between the Pfizer and the Moderna vaccine? One is a 4-week, one is a 3-week, how cold you have to keep it. But on the sort of a cellular level, what's really different between those two, or isn't there?
Eric, you want to grab that?
Sure. It's really just how they were formulated. So there's different proprietary, they're both mRNA vaccines, and they both use lipid fat droplets to help deliver the mRNA to our cells. They're just formulated slightly differently, the way the companies formulated it. And really it's based upon their study design, how much of a dose they gave, and how much in their early phase 1 and phase 2 trials they waited to look at immunogenicity. So that's kind of why people ask, well, can we adjust the number of doses? Can we adjust the timing? And really, my concern is that we have to stick with the kind of the guide rails set up by those phase 3 trials that really showed to us and scientists and medical community that these vaccines work as long as you get, is it 1 dose for Johnson & Johnson or 2 doses for Pfizer and Moderna, spaced out 21 or 28 days apart.
And that raises another question that I got from Lori. Do both shots need to be the same brand, Pfizer and Moderna?
Yeah.
Hillary?
Absolutely. Yes.
And what if could you then switch down the road? If we start getting boosters, can we go to a J&J? This raises a lot of questions about mix and match.
I don't think we know enough about, long-term impacts. There's been some interesting articles written about a little mix and match literature. I think it was in the Journal of American Medical Association last week from a gentleman from Cornell about, the potential to use a different vaccine type based upon what may be circulating and its efficacy versus some of the variants. I mean, some people may actually use some, when we eventually get this Novavax vaccine out there, which is a protein vaccine, or the potential that people could get a Johnson & Johnson vaccine as a on the back end of Moderna. But those studies haven't been done, so no one's going to start playing with that formula just now, but we'll learn more and more. So there's a reason to right now. I think we'll get our vaccine supplies bolstering, and if we get AstraZeneca and Novavax in April or May approved, which may happen, we'll be even in better shape. But the idea that we're going to start playing a kind of a roulette with it doesn't make any sense, I don't think, from an immunity standpoint.
And the questions all, they sort of run along that. And then there's something I'm curious about as we start to hear about better treatment for COVID-19. And it ties in with another question that I'd had from a viewer about resistance to taking the vaccine. So the more we hear about treatments, do you foresee a time where people will be more resistant who are already not crazy about taking a vaccine, but will be more resistant to taking the vaccine as treatments improve?
Yeah, this is a pandemic with nothing better than dexamethasone as a treatment to date. I mean, the antivirals haven't proven effective. We know the hydroxychloroquine story. Just recently, there's some literature from South America, from Colombia, on ivermectin, which is a parasitic agent. It didn't prove to be positive. So we don't really have any good treatment per se. I mean, probably the best thing we have outside of prevention right now is the use of the monoclonal antibodies that are out there for people who are not hospitalized, but to prevent hospitalization. So, I think we're going to be waiting a long time for an effective antiviral. We waited 15 years for an effective antivirals against HIV disease. It is not easy to make an antiviral medication.
Yeah. Anne wants to know, she has a friend who had a bad reaction to the first shot. Should she get the second jab?
I guess that depends on what the reaction was, and she needs to consult with her physician.
Yeah. I mean, feeling crummy is one thing. If you have what is happening? I mean, the numbers are so very small, but for someone who has an anaphylactic response to the vaccine, are they getting the second shot?
No. No, if they have a severe reaction like that, it's halted. We have some idea, and I think getting back to that question the viewer had about sulfa drugs, is these companies have been pretty transparent about what's inside the vaccine, so they can hopefully inform clinicians when a patient comes up, will this patient be a good candidate for the vaccine?
Yeah.
And they're still working out, is it the PEG, is it the polysorbate that's causing the allergic reactions in some individuals? And there is kind of a gradation, as already mentioned, is if someone has like a minor response, then perhaps they can get their second dose. If someone has a more severe anaphylactic reaction, they can't get the dose. And that gets to your previous question about therapeutics. And as Alan mentioned, we don't have a cure. So first off, for people that resist the vaccine, I think you need to realize there's no magic bullet or cure out there. If you get the disease, you're at risk for complications. And we're just beginning to understand the long-term complications. So it's better not to get the infection at first than to just wait for this cure that may not come. So there's been a number of therapeutics that look promising, but as Alan mentioned, when more scrutiny is performed on their studies, they kind of fall apart.
Yeah. Marlene wants to know that she read if you had an allergic reaction to colonoscopy prep meds, that you could have a reaction to the vaccine. True, false? Help us out to understand this.
You know, I guess I consult with an allergist, immunologist about what the actual component of the, I mean, if there was some propylene glycol or polyethylene sorbate or something like that in the colonoscopy prep, Miralax or whatever else they were taking, or some other, you know, agents, a cathartic. I just make sure you review all the ingredients that you, but it's never really clear what exactly in a preparation that has multiple ingredients caused your problem. So, I mean, I would, you know, consult an allergist, immunologist. It's not, that's probably the best way to roll with it before you deflect against a vaccine. I mean, I don't know what the Novavax vaccine is going to have in it for its adjuvants or anything like that as the additive. So these are pretty benign vaccines overall compared to what we have on the market for a whole lot of other diseases.
Which is an interesting comment because people think that this is just the opposite. You know,
these are, these things came out really rapidly. I mean, I'm sure Anthony Fauci would say he was shocked that we got a vaccine out in 8 months. And most immunologists, virologists, folks like Eric on here, it is amazing what we did so quickly. So people are a little spooked about the alacrity with the, rollout of a vaccine that is just still not FDA approved. They're all being given under an emergency use authorization because of the pandemic. I mean, we had to do it. So I think people are just, a little bit afraid. And, it wasn't endorsed by a lot of people when we finally got it, and that's too bad. I think now we're doing a much better job of promoting it.
Yeah. If Justin wants to know if a spouse just recovered from COVID and their spouse is now positive, so one had it and got well, the other one is now positive, can they still sleep in the same bedroom?
Well, you're the infection control individual.
So just
don't get involved in their marriage.
So, yes, having just recovered from COVID is probably like the best time if you're going to be exposed to somebody else who's positive. That's the time to do it. That's where you've got your cape. Keep in mind, there are no silver bullets, but if I were to be exposed, it would be under that situation that I would find it to be ideal. So yeah, I would share the bed. That's a safe time.
That's a safe time. And if everybody is vaccinated and you're 2 weeks out, the odds are you're not going to be sick, but there is a very small percentage that you could be infected and transmit that to someone else, which is why we're still being told to mask up and social distance, to come full circle, correct?
Correct. Yeah, I think if you look at the experiment in nature this year is influenza. And how is it that we had a year when at this point in time, in terms of the weeks of the usual flu season, we had 6,000 deaths last year in the 2019-20 season. There's been 143 so far. I'm sorry, 413. There's only been one infant that died in the entire country so far this year. We usually have 180 over the flu season. No one's gotten the flu, and it's not because of the flu vaccine being so great or everybody signed up to get the flu vaccine. They're not getting the flu because they are wearing masks and social distancing. So obviously, SARS-CoV-2 is more transmissible than influenza because people are still getting that. But if you ever want to impact somebody about why you should be wearing a mask right now still in social distancing as this thing is starting to go down but persists, look at influenza numbers. It's just unbelievable. All over the world, there hasn't been any flu this year. And that's not because flu is competing with COVID for a place in everybody's body. It's just we did a great job by staying up. I mean, I'm not saying it's a happy time, but masks work.
Before I let you go, Darius wants to know, are we going to have to take this vaccine every year like we do a flu vaccine?
To be determined. I mean, it's kind of pointing in that direction as a kind of more of a stronger possibility with boosters. But again, it's to be determined. I think it depends on how a lot works out in our favor. We were kind of, as Ellen mentioned, we're fortunate. We got a vaccine in a year, which is fantastic. Is that going to carry us forward? And maybe, I don't think we'll ever get to the point, unfortunately, where we can eliminate SARS-CoV-2. But again, if we can get it to the point where we have to get a vaccine yearly or biannually, and we're able to return to, visiting grandkids, grandparents, and doing the things that we missed over a year ago, I think that's, a good trade-off to having to get a shot once a year, in addition to our flu shot and some other shots.
Well, I want to thank you all. I know we got started a little late, but we managed to get our full half hour in. So I hope we got to, I know we got to a lot of the questions. I had questions from before, and I was following along and trying to get to as many of your questions as possible. I want to thank you to our guests, Dr. Alan Sanders, Dr. Eric Yeager, Hillary Allison, and thank you, really, for spending time with us tonight. And remember, News Channel 13 is your vaccination station, so share your questions in the coming days, and we'll continue to get you answers. And you can always check the link section on our website for the latest information. So mask up, stay well.